Hi, hello. Thank you very much for the opportunity of having a presentation here. My name is Sophia. I'm a consultant in obstetrics from the University Hospital in Ulm, which is in southern Germany, just in case you haven't heard of it. And today I will present our work on neonatal outcome after implementing physiological CTG interpretation, which is the sort of interpretation Austin was talking about this morning. So just to give you an overview of what obstetric care looks like in Germany. And there is a national guideline that says we are supposed to use the FIGO score. And in reality, however, we did a survey, and units in Germany really just do what they think is right and not what guidelines say. So some obstetrics units use scoring systems that go back to the 1980s. Quality assessment in Germany only focuses on neonatal outcome. It doesn't look at how we interpreted the trace. And FBS, so fetal blood sampling during delivery, is mandatory if you have a pathological trace in Germany. And then, which I find is quite distinctive only for Germany, obstetric care takes place as an outpatient. So we have high qualified obstetricians in an outpatient setting. So women are being looked after in outpatient departments, and they come to hospital to have their baby. Nearly no mum has their baby at home. There are birthing centers, but they are not very common. And I just looked up the numbers, and so it's about 580 hospitals and 120 maternity-led, midwifery-led birth centers. And last year we had about 650,000 deliveries in Germany, and that makes approximately 900 deliveries per unit. So that's not a lot if you think about it. And so we have a very heterogeneous group, really, in Germany. And the hospital I'm from was the sixth largest in terms of deliveries last year, with 3,500 deliveries. And within this setting, we decided to change from the guideline that says do use FIGO to physiological CTG interpretation. And when we talk about physiological CTG interpretation, what we mean is that we don't want to talk about a simple classification system or a scoring system, but we want to talk more about understanding how this baby is responding to hypoxic stress during labor. And the key question that we're asking is this fetus still compensating, or is it decompensating in labor? And to explain this, we came up with this cascade, which is just a summary of all the work that is out there. And it tries to link the underlying cardiovascular adaptation with the fetal heart rate patterns that we see on the CTG. And so how do we make use of it? It's like a how-to guideline that was published from the physiological CTG guideline. And the first step is that we are supposed to know the full clinical picture. So we have to know all we can about mum, about baby, about labor and labor progress, about what has happened so far and how labor is going on. And we need to be aware of our human factors. So we need to know how many midwives are there. Are they looking after any other deliveries? Did they have a bad outcome the day before? And we need to take all of this into consideration when we start interpreting the trace and we start looking after mum. And then we have also the Baby Fit for Labor checklist, which is something that we do at the start of labor. So we're looking at, is the baseline appropriate for gestational age? Are there flat decelerations? Are there accelerations? Is baby cycling? Does it look like we want a trace to look like at the start of labor, really? And once we decide baby is fit for labor, there are 3 questions in labor, which is the baby exposed to hypoxic stress, which is usually yes, because whenever you're having contractions, you know there is a deficit in oxygen. And then the question is baby compensating for that stress? And this is always the case if baby is still spending enough time on the baseline with a normal variability. And there will be decelerations, but they are fine as long as baby is enough time on the baseline. And there will be and might be loss of cycling, as we think baby will not move as much and will probably not go into deep sleep during active pushing, which is logical, really, if you think about it. And there will be a rise in baseline due to catecholamine surge. And this is also a compensation and is not considered a decompensation yet, as long as oscillation or variability is still normal. And the third question would be, are there signs of decompensation? And this is always the case if we can't put our finger on the trace and say, well, this is the baseline. So whenever we're talking and discussing, oh, the baseline is down or it's up, then it's not a safe baseline. Or if baby is not spending enough time on the baseline. And if variability turns out to be abnormal, which is below or very saltatory or zigzag pattern. So here you can see the timeline, how we implemented it, or how we came towards physiological CTG interpretation. It wasn't done within a day. It took from 2019 to 2022. And we didn't get any additional funding for it, so we used a multimodal approach which really combined very low-cost strategies. So it was a lot of training online, and COVID came, so it was only 5 people in a room, and we just had a lot of case discussions and a lot of theoretical teaching for the whole team. So what we're looking at now is the implementation, before implementation, which was the whole year of 2018, and after we fully implemented physiological CTG interpretation, which was in May 2022. And we wanted to see if there was any association with clinical changes in outcome compared to before. We included all pregnancies that had an intended vaginal birth, so we excluded all primarily planned cesareans. And we first compared maternal and pregnancy characteristics before and after, and as you can see here, they were broadly the same. So we had a little bit of rise in BMI, we had less hypertensive disorders because we started delivering them before 37 weeks, but it was basically a very similar cohort. So these are all the intrapartum characteristics. We looked at more than 120 variables during labor, and those are the ones we find the most important. And I just want to guide you through them. So if you use physiological CTG interpretation, or however you want to call it, it's more about delaying labor and trying to reduce hypoxic stress, which means you use a lot of more tocolysis and a lot of less oxytocin. So we doubled our use of tocolysis and bolus tocolysis as well. And we had a reduction in oxytocin. This, of course, led to a prolonged labor, which is also coinciding with the guidelines saying that we don't have to have a baby within 2 or 3 hours after active phase. So we are now allowed to have whatever time we want to have, basically, as long as there is progress. So this is not only due to our tocolysis management, but labor was nearly an hour longer after this. We also, so there are two interesting things. One is we have less malpresentation, which might be because we didn't intervene so much, or we might have calmed down labor more. And we had less episiotomies without changing anything in our local guidelines or national guidelines. And we performed way less fetal blood sampling, and last year our numbers go down to 5 in total, so 5 FBSs per year. And then the other thing that came to our attention was that we had a higher blood loss, which was probably because of tocolysis, and we did a multivariate analysis on this as well. And the thing is, you need to know is we don't regularly give oxytocin in postpartum, which we should actually do. And now we just started giving a woman 3 units of oxytocin after delivery once she had tocolysis during labor. But the blood loss increased by about 50 milliliters. And then, so if we look at the outcome, our primary neonatal outcome was a composite marker of neonatal morbidity. And we didn't use HIE because it's such a rare event. We used, the definition was admission or transfer to neonatal unit plus any objective sign of compromise, such as low arterial pH, high base deficit, or low 5-minute APGAR score. And here we can see that basically the neonatal parameters that we have, they were all decreased by roughly 1/3. And to understand whether this was an independent effect, we performed a multivariate analysis using the composite neonatal outcome as a dependent variable. And we wanted to know whether the study period itself before and after implementation remained independently associated with neonatal outcome after adjustment. And so this is what we did. And as you can see, it did have an input. So being in the post-implantation period with an intended vaginal delivery decreased or was associated with the reduction of 1/3 of risk of adverse neonatal outcome. And we also did propensity score matching, which confirmed this result. Then there's one thing, if you look at our intrapartum, postpartum characteristics, it's the delivery mode. And at first glance, the cesarean section rate appeared to increase after implementation, which was very concerning because other findings from the UK suggested that physiological CTG interpretation would actually reduce cesarean section rate. So we had another close look at this and adjusted within a multivariate analysis and also with the propensity score matching. And it showed that in the post, so if you look at the study group and the influence on cesarean section, the odds are below 1. So it's actually a little bit even associated with less cesarean section. But it's not significant yet. So basically, the summary was that after implementing physiological CTG interpretation, we had a reduction in composite neonatal outcome in pH less than 7.15, 7.10, 7.0. We had no changes or didn't influence our cesarean section rate, and we're performing less FBS, but we did have an increase in postpartum hemorrhage. And what has happened now in Germany is that our guideline is being reviewed and is being changed, and they start, so what we know so far, because it will only come out in October, but they are going, so they're taking out the FBS as an obliged offer. It can only be considered now, so this is a changement in our guideline, and there will be more impact on looking at the baseline and baseline changes during labor and at the beginning of labor. So yeah, we're still at the very beginning in Germany, but we're hoping to have maybe influence at least the national guidelines, and we're doing a lot of training in Germany, which so far we have reached more than 12,000 midwives and obstetricians and teaching on physiological CTG interpretation. Thank you.
Thank you. Any questions? There must be questions.
Sophia, thank you for presenting your departmental data. They're very interesting. I was wondering why you presented the difference between 2018 and 2022-23 in terms of occurrence of fever, but you didn't present your epidural rate data. And what do you think is responsible for the, for the fevers, if not epidural?
So we have less fever in the 2020 cohort. Let me see.
Yes.
So
So you've got more fever.
Yeah.
In 2022-23 compared to 18.
We can have a look at epidurals, yeah.
Well, because 95% of your fevers will be attributable to epidural.
From what I'm thinking is that maybe we only started looking at maternal temperature later on.
Right, okay.
So it might have been
okay.
Something to do with this. But we do have the epidural data as well, and all I know is that it didn't change in percentage.
Okay.
But I can do a correlation.
Yeah.
Thank you.
Have a look.
I'll have a look. Thank you.
Any other questions, please? Yeah.
Yeah, if you adjust.
Are you happy for me to touch?
What?
Can I touch?
Sure. Mom?
There you go.
Yeah, so I think the volume increased because we used more chocolysis and because labor duration was longer. And then for the cesarean section rate, it did increase if you look at the numbers, but it didn't have, but the the change to physiological CTG interpretation was positively influencing cesarean section rates. So what we said was that there was no change due to cesarean section, but we had more cesarean section intrapartum due to other reasons and not due to CTG reasons.
Okay, thank you.
Did you classify the vacuums as well, whether they were emergency or not?
The vacuums?
Yes.
We don't do emergency vacuums.
Oh, okay.
So we do emergency cesareans.
Right.
But what's an
Oh,
emergency?
for fetal indication, if you have a bradycardia and you put a ventouse on, is that an emergency vacuum?
We don't differ between, unfortunately.
Okay, awesome. I think my job is to make sure that we get to the hallucination talk before lunch. And I just admit that I love the title, so I'm looking forward to what
Somebody
Gary
find
has to
one.
share.